Hey, everybody, welcome back to the podcast. Pardon the mess a little bit behind me. If you're watching this on YouTube, if you're listening on the podcast, on the audio stuff, then you won't see the mess. We're rearranging the podcast studio a little bit, but I wanted to take an opportunity to introduce our guest on this episode. This is a fantastic guest we have here. So this is Dr. Awais Aftab. Dr. Awais Aftab is a psychiatrist in Cleveland, Ohio, and a clinical assistant professor of psychiatry at Case Western Reserve University. He completed his psychiatry residency from Case Western Reserve University and University Hospitals, Cleveland Medical Center, and geriatric psychiatry fellowship from the University of California, San Diego. His academic work has focused on philosophy of psychiatry, critical psychiatry, psychopharmacology, and psychiatric nosology. He has received numerous national awards and honors, including the prestigious Laughlin Fellowship by the American College of Psychiatrists and the American Psychiatric Association Leadership Fellowship. He led the popular interview series Controversies in Critical Psychiatry for Psychiatric Times, and a book adaptation of this series is forthcoming from Oxford University Press. His peer-reviewed scholarly work has been published in journals such as the American Journal of Psychiatry and JAMA Psychiatry. He is an associate editor for Current Psychiatry, senior editor for the journal Philosophy, Psychiatry, and Psychology, and he has been actively involved in initiatives to educate psychiatrists and trainees on psychiatric controversies. He has a wonderful Substack called Psychiatry at the Margins. Everybody should check that out and subscribe. We'll drop a link in all of the notes and description and stuff. It also has his own website. But this is a great conversation. Hope you guys learn something. We delve into a lot of the controversies that are within psychiatry and discuss those things. So enjoy. All right, everybody, welcome back. We have a wonderful, wonderful guest we have on our show today, Dr. Awais Aftab. And before I let him introduce himself, I tweeted something out about how excited I was to have him on the show. And I wanted to kind of read what somebody said, because it kind of showed kind of how important, per se, and how excited I am to have him on the board or on here. So this is Dr. Ryan Kabir. Ryan Kabir is actually a psychiatry resident over, where is he at? In Louisiana, or Louisville, I think. Louisville, right? I almost ended up in Louisville. I really like the program. It's a great program over there. But he writes, he's one of the biggest reasons I went into psychiatry. I used to be anti-psychiatry, but working with seriously mentally ill patients, seeing patients get better, and yes, some harmed, and reading his work along with others put me in the critical reform camp. Still have much to learn. So much to learn. So I think that was like a high praises I think I've seen. So welcome, Dr. Aftab.
Thank you. A pleasure to be here.
Yeah. So tell us a little bit about yourself, some of your introduction, background, all that stuff in your own words.
Sure. Yeah. I guess we'll kind of start with the basics of what I'm doing right now. So I'm a psychiatrist in the Cleveland area. I have an academic appointment through Case Western Reserve University as clinical assistant professor. So I'm involved with the teaching of psychiatry residents, with medical students, and I do clinical work in the inpatient setting, mostly working with serious mental illness, schizophrenia, spectrum, bipolar, etc. And my academic and scholarly interests are quite conceptual and theoretical. So I've been interested in various sorts of conceptual and philosophical issues that relate to psychiatry, and I've been kind of active in this field, and sort of an active participant in the discussions that are taking place. And in addition to that, in addition to the philosophy of psychiatry side, I have been pretty interested in this field that's broadly known as critical psychiatry, and talking to people and learning about that, and I there was this interview series that I did for 3 years for Psychiatric Times called Conversations in Critical Psychiatry, which basically involved talking to many of the prominent names who had offered different sorts of philosophical and other scientific critiques of psychiatry. And we actually have, there's a book adaptation of that series coming out from Oxford University Press later this year.
Super, super exciting to have that. I think it was like such a good series. I was able to kind of I didn't read it all, but I was able to go through it all and kind of have an idea of all that. So, first question I wanted to ask is, we have the field of psychiatry as a whole, and it's come under kind of critiques and all the things, but you're known for the philosophy of psychiatry. What does that mean? What does that even mean?
Yeah, so it's a philosophy of psychiatry, or sometimes it's called philosophy and psychiatry. It kind of refers to this broad intersection of psychiatry as a discipline and philosophy as a discipline, and it's kind of similar to sort of like how we have philosophy of physics and philosophy of biology, philosophy of medicine, and it refers to a couple of different things. One is that it's basically a philosophical inquiry into the foundational concepts of psychiatry. So the concepts that psychiatry works with, so things like notion of mental illness, mental disorder, psychopathology, sort of like like what does that mean? Sort of like when we make judgments of a psychological condition being a disorder, like what are we saying? And sort of like what is involved in these judgments? Sort of like what is the relationship between objective facts and different sorts of values? Sort of like what is the nature of these phenomena? How does that relate to the physical world versus sort of like the social processes that exist in society? So there's sort of like this whole aspect of a philosophical understanding of foundational concepts that exist in psychiatric profession. Then there's this other strand which looks at psychiatry as a scientific discipline and uses sort of like methods from philosophy of science as well as other philosophical specialties and applies them to psychiatry. So it's sort of like it sees sort of like psychiatry as a specific scientific discipline and understands it sort of like within this broader context of philosophy of science. And then there's another sort of like strand, which is it uses psychiatric phenomena to try to inform our philosophical understanding of different issues. So, for example, using various psychotic phenomena like delusions or hallucinations. And so a philosopher would sort of like, examine delusions, sort of like, think about them and try to sort of like say, what does that tell us about the mind? Or sort of like, if we take cases of patients sort of like, who are experiencing, let's say, a thought insertion or thought withdrawal, sort of like, like these sorts of unusual phenomena, like what does that tell us about sort of like the nature of mind and nature of mental processes? Or someone else might sort of like look at dementia and sort of like the way Alzheimer's affects memory, and they might sort of like say, what does that tell us about the sense of self? So these are these different strands that exist in this broad intersection of philosophy and psychiatry that go under this umbrella name of philosophy of psychiatry.
What brought you into it, and I guess how did you get intrigued by this? Because I think when we go through training, I think you've got a few years on me on this, but when I went through training, I was like, oh, we're just doing medicine stuff. It's real medical school, and learn a bunch of medicines and diagnose and slap some stuff and see patients in the outpatient, and boom, that's it. What brought you to this? I guess this deeper level of understanding of being like something different.
Yeah, I really was interested in philosophy, sort of like since my teenage years, and I had really sort of like I think I wanted to go into professional philosophy, but I grew up in Pakistan. That's where I did my med school as well, and basically sort of like going into professional philosophy or academic philosophy wasn't really a viable kind of path there. So I ended up in med school, and I realized pretty quickly that psychiatry was kind of like the only discipline that I could relate to, that sort of like that spoke to me. And I was fortunate that psychiatry also had this sort of like it offered this opportunity, and sort of like it had this rich kind of like philosophical side to it, that you could sort of like ask these questions in very sort of like meaningful sort of way. So given that I had sort of like an interest in philosophy, and sort of like I had kept up with sort of like the literature on philosophy during my med school, it was kind of natural that I started sort of like thinking about psychiatry from this philosophical way. But as I was going through my medical training, I started getting exposed to a lot of sort of like critiques that psychiatry sort of like is subject to, the anti-psychiatry movement, various other sorts of things, and those questions, a lot of them are quite philosophical in nature as well. I think sort of like the discussion of may sometimes take a more anti-philosophical turn, but I think the fundamental questions that they bring up are philosophical in nature. So I started thinking about those, and I sort of like one of my professors of psychiatry in med school, he recommended that I read Irvin Yalom, who's a psychiatrist and sort of like psychotherapist, well known for existential psychotherapy, and sort of like his work opened up sort of like a whole new dimension and a whole new way of thinking about psychiatry as well. So I was really fortunate that I had these early influences. And I was able to sort of like think about medicine and think about psychiatry in a way that is not part of the standard medical curriculum.
Yeah, and I think it's really interesting because when we're coming through, we definitely have the people that are very much like, we're just going to be sitting in an outpatient office seeing patients, and that's that. And I think when I kind of started off a little bit, like that was some of my mentality, right? Some of what I was thinking of doing. And I've seen more and more as you're out in the real world and you're spending years with patients now versus a rotation with them for a period of months, or maybe 1 year total you may spend a time with them during one of your residency years. The medicine stuff matters, and I mean medicine in regards to like the pharmaceutical stuff matters so much less, right? And there's so much other aspects, especially, and again, I work in a very different population than what you are, with more of the seriously mental, and I do more of kind of the, I don't want to say the worried well, but more of the anxiety, depression, ADHD, and I'm primarily children, adolescent work, but still, like, there's so much of the other things that matter, the therapy aspect, and what is the basis of this. And I think there are people that are drawn to that so much more, and it makes such a huge difference. And it was interesting because I've only been doing more of the twittering and the social media stuff in the past year and a half or so, where I've seen this whole other world. Again, the critical psychiatry. I'd heard of anti-psychiatry to an extent, but not to the extent that that we're in a kind of, we'll say, we're in a little bit of a group chat where this is part of the thing that comes up a lot. But tell us about that, I guess. So differences between anti-psychiatry and critical psychiatry.
Yeah, it's a so it's a difficult question to answer, and I think the difficulty comes from the fact that the term anti-psychiatry is used in a variety of different ways, and sort of like and some of the uses of the term are more neutral versus some of the other uses of the term are sort of like more pejorative, and so in a somewhat simplistic sort of way, like one strand of thinking about anti-psychiatry is sort of like is in historical terms, and sort of like looking at a couple of key figures in the 1960s and 1970s who presented sort of like very sort of like fierce conceptual and philosophical challenges to the legitimacy and authority of psychiatry. And so, these figures involve Thomas Oz in the U.S., R.D. Laing in the U.K., Michel Foucault, the philosopher from France, and sort of like there were others as well, but sort of like these were some of the more prominent figures, and they really kind of sort of like brought up sort of like difficult sort of like questions about sort of like the nature of mental illness, and sort of like the meaning of psychosis, or sort of like sort of like how medical authority and psychiatric authority operates, and and so all of these questions, sort of like the questions that they asked were in many ways sort of like genuine, meaningful questions. With people like Thomas Zaz, I think sort of like there's a general sentiment that in how they attempted to answer those questions, they kind of like went in a wrong direction and ended up sort of like adopting answers that were kind of on the whole more harmful and misguided. But they were really sort of like, I think, undertaking an inquiry, sort of like that was meaningful and sort of like sensible and academic and intellectual in nature and generated a lot of activity. So that's sort of like there's this sort of like this academic intellectual strand of anti-psychiatry that goes back to this 1960s 1970s, and there's a lot of scholarship that follows that. And then there's this other strand which is sort of like a little bit more kind of populist in nature, and it's more similar to sort of like how we conceptualize the anti-vaccine movement or the anti-vax movement. So it's basically sort of like driven by these sort of like closed echo chambers where there's a lot of misinformation and sort of like there's a lot of distrust of authority, and sort of like there's a sort of like anti-scientific kind of like ethos, or sort of like and and so like and I think a lot of people when they think about anti-psychiatry these days, they're kind of thinking of this second aspect sort of like in the same sort of way as the anti-vaccine movement, but sort of like from an academic perspective, one could ask these philosophical and historical questions about anti-psychiatry that without going into all of this conspiracy theories, misinformation, etc. And then another thing sort of like that makes this whole thing confusing is that we have the sort of like the harmed patient movement, sort of like the survivor movement, which has been kind of going on in parallel, sort of like for decades now as well, and sort of like and their influence, I think, sort of like is mixed in with sort of like all of these other developments at the same time as well, but in some ways sort of like they're distinct from these anti-psychiatry stuff. So I think if we talk about, so these days sort of like in academic circles the term critical psychiatry is sort of like is used more commonly, and I think partly the term became more popular as a way for people to distance themselves from this pejorative connotations of anti-psychiatry, sort of like saying that we're not in the business of like misinformation, we're not in the business of conspiracy theories, we're trying to do something intellectual here, we're trying to do something scholarly, sort of philosophically oriented. So it has its roots in the sort of like critiques of the 60s and 70s. So there's no sort of like hard and fast distinction between philosophical critiques of the 60s that we call anti-psychiatry and the sorts of critiques that we see now, except sort of like I guess the sort of like classically how people say is that critical psychiatry is more about sort of like reforming the profession, sort of like trying to sort of like improve it without necessarily trying to abolish it. But so I think sort of like these explanation, if you look at them sort of like in a more sophisticated historical sort of lens, they're difficult to kind of justify in some ways. But that's the general perception.
Yeah, no, it's hard because I think we run into these issues with things like social media and Twitter where we're limited in the amount of characters that we can use, and then it becomes this very black or white thinking, and it becomes like, well, if you're saying anything against psychiatry, then you're an anti-psychiatrist and you want to abolish the field and you want to kill me, right? And that's the kind of the things we run into. And of course, there are the people that we get. I'm sure you get the messages too that like, oh, you're raping the kind of like society and drugging children and blah 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 that's out there. And it's like, no, it's obviously you're those people are on the fringe. But I think the critical psychiatry movement, how anti-psychiatry kind of started as a whole, it came out of a place of wanting to reform things and make things better, right? I don't think there was anything necessarily wrong with it. And I think there is, we see this stuff in the field. We have a stereotype in the field. We have a stereotype in media that's out there that's not fully wrong.
Yeah.
So there is that aspect of it that it can improve and we can make those differences, hopefully.
Yeah, I think sort of like I think there's a difficult history. I think there I think that applies to like medicine generally. I think if you look at the history of medicine, there's a lot of sort of like dark periods and sort of like terrible things that have happened, and and that's also the case with psychiatry. except sort of like in the case of psychiatry, the patients were in a much more sort of like powerless position, and sort of like and a lot of things sort of like they were subjected to many sorts of traumatic and abusive sort of like experiences in the name of psychiatric care and psychiatric treatment. I think sort of like everyone is aware of the conditions in asylums were, for example, in the 20th century, which led to sort of like a fierce backlash. And then I think it's also the case that the nature of some of these conceptual issues is a lot more ambiguous, in psychiatry. When we talk about mental illness, it has a certain sort of like abstraction to it that doesn't exist in sort of like some of the more other areas of medicine where you can point towards pathological changes or infectious organisms. So there's that sort of like that degree of abstraction, I think, makes it make things more challenges, sort of like and I think sort of like people prefer to think in sort of like more concrete terms, and so it brings a certain amount of like uncertainty to it, sort of like like what are we talking about, and humans sort of like when we're dealing with human phenomena, everything is seen through layers and layers of interpretation, and there's such an influence of social and cultural values. So we just like we're the concepts that they're working with in psychiatry, they're just sort of like subject to a lot more disagreement than sort of like similar sorts of concepts are in rest of medicine.
Yeah, like I mean, I was just talking with somebody else about like how Dr. Amen has kind of come to notoriety to an extent, but how he's become at the same time so popular is because, one of the main criticisms of psychiatry, the most common one is that, there's no blood tests, there's no imaging, you can't pull out a stethoscope and hear something, right? So somebody comes along and is like, aha, I'm going to start doing SPECT scans, and here I'm going to show you holes in your brains, and people latch onto it because they want to see something. They want to see something. They want to feel something. They want to be able to look at something and say, this is why this is happening. So that's, one of the disadvantages that we have in the field. And I think it opens up a lot of problems and some things that we can always kind of improve a bit.
Yeah, I think it's sort of like it gives rise to this sort of polarizing tendency where either you sort of like become very concrete and start thinking in terms of like brain diseases and at the level of the brain, or you sort of like or you start rejecting the reality of sort of like mental illness and sort of like psychiatric diagnosis, and you start saying, oh, it's all a myth, like just because you can't find consistent brain differences, you're like none of this mattered, none of this is real, it's all fake. So I think sort of like it's this it sets up this sort of polarizing tendency, and I think the key is to realize that we are dealing with sort of like phenomena that are inherently psychological, sort of like that are at the interface of sort of like brain and society, and that as long as we approach the subject with some sort of hidden reductionism, as long as we privilege the brain, we're either going to be sort of like this sort of brain reductionist, or we're going to be this sort of social constructionist, because we are we can't think of illness concepts in terms other than that of bodily changes.
Yeah, it's really hard. And I think that's kind of like it comes to the next thing where it's like, diagnoses versus formulations, and, DSM versus all these alternatives that are kind of popping up. And talk about that a bit, like in regards to, when I talk to people about the DSM, there's the clinical understanding of that, hey, the DSM is a communication tool, it's an insurance tool, it doesn't mean much. But then there are people, I guess, in society who are not in the field who are like, well, the DSM is the Bible of psychiatry, and you guys are using the DSM against us. It becomes almost this big villain when it's not meant to be at all. And diagnoses as a whole are not meant to be this kind of concrete box that we're putting people into.
Yeah, yeah. I think sort of like there's this I think kind of curious history of sort of like how DSM acquired its sort of like its current status, and how it's used by professionals within the field, and how it's understood by society at large. And I mean, and like I said, sort of like, the reality is that it was a tool intended to establish some degree of reliability, sort of like, because what we were finding in the 50s, 60s, and 70s was that there was tremendous disagreement among psychiatrists when seeing the same patients. So like, two different psychiatrists would see the same patients, and they wouldn't even sort of like agree on like what the diagnosis is. Like it was like sort of like, it was almost like random. So and even sort of like, diagnoses like schizophrenia were being used in wildly different ways. So the where sort of like DSM came in, especially sort of like the modern version starting from DSM-3, is that they're like, okay, sort of like, at least we are establishing dictionary definitions. We're sort of like, we're kind of as a field deciding that this is what we mean by this term, and this is how we're going to use it. So it provides us with a shared language. So so everyone is on the same page. And if I use the word schizophrenia, you understand what it means, and if you use bipolar, I understand what it means. So it sort of like it provided us with these operational constructs. It provided us with a shared language. But then as it started being used more and more, and it became sort of like sort of like the primary sort of like language which psychiatrists were using, it started being used for public communication. And sort of like so all sort of like all the newspaper, all the media, they're certainly sort of like using the language of DSM. And in sort of like also like in 80s and 90s, we start seeing different sorts of anti-stigma campaigns and patient education campaigns. And we have with the rise of the internet, we have sort of like patient education websites, and all of them sort of like they're like, well, we have to talk about depression, or we have to talk about anxiety, sort of like so like what's the scientific sort of like standard that we have. And they're like, oh well, sort of like psychiatry has the DSM. So suddenly sort of like all of the communication about psychiatry that the public was getting was through the language of the DSM. So it created this sort of like exaggerated importance in the mind of the general public, that sort of like that as if the whole legitimacy of psychiatry hangs on this manual. And not only that, it created like a misunderstanding about sort of like the nature of these diagnostic categories. It sort of like it became this idea that, oh, like DSM diagnoses refer to different disease entities. That if we sort of like say that one person has major depression, another person has generalized anxiety, they are two different disease entities, as if sort of like they are two different sorts of brain disorders that exist, when in fact sort of like these are just sort of like symptom patterns. We're not saying anything about sort of like how the etiology is different, or sort of like, or even if there is a categorical difference in their brains or anything like that. These are essentially sort of like descriptive symptom patterns. But the idea that sort of like the public got was that, oh, the DSM is a disease model, and each diagnosis refers to distinct diseases. And then each sort of like, and this kind of like got mixed in with the chemical imbalance kind of ideas. So each disorder had its own kind of like unique chemical imbalance or whatever. And I think that just sort of like set us up on the wrong path, because one, it really negatively influenced the self-understanding of patients. Like when patients got their diagnosis, they started thinking sort of like in terms of the DSM and in terms of this sort of like popular disease model. And sort of like and then and when they would investigate the scientific literature, it set them up for disillusionment. They would be like, oh, like I had this image of sort of like psychiatric conditions as validated diseases, but look, there's no brain difference, or there's no brain findings, whatever. And they're like, it's all fake, it's a scam, right? So I think the whole situation is like really unfortunate. And I think this is one area where the profession, I think, kind of sort of like fell short of what it should have been doing, is that it should have been paying attention to this communication aspect. I think the profession kind of became a little bit complacent in relying on these categories for the purposes of communication, without clarifying to the public the real nature of the manual.
Yeah, and I think that's a really important part that to bring it up, is that we think of psychiatry as like a very secretive thing. And I'm I'm not sure how your training was, but like we were taught to be like pretty secretive and keep to ourselves a little bit. And it unfortunately we couldn't do that, right? The media and the world has brought us out there again, all these mental health campaigns that we wanted, mental health awareness, they kind of worked almost against the aspect of keeping everything secret, because now everything is out in the open. Exactly like you said, you can buy the DSM on Amazon now, or it's however much, and it's just, there's apps for it. You can open it up, and then I have patients who are essentially reading it off to me and telling me their diagnoses. And I was like, I remember even just somebody I was seeing earlier today was talking about, oh, I think I'm CPTSD versus, and my borderline traits are, and my autism. And I was like, we're just using words right now. Like, all
Right.
these things, it doesn't matter what your diagnosis is. Not so much, right? We're just trying to see what your distress is and how we can kind of manage that.
Right, and I think you mentioned sort of like the diagnosis versus formulation kind of dynamic as well, and I think this is also kind of unfortunate because historically the diagnosis is supposed to be embedded in a comprehensive formulation, and sort of the formulation is sort of like where the meat of the conceptualization is, and sort of like where different clinicians sort of like use their different theoretical backgrounds to come up with an idea of like what's going on here. So a psychodynamically oriented psychiatrist would sort of like would conceptualize the patient differently than sort of like let's say a cognitive behavioral one or a biopsychosocial one, right? So the formulation is sort of like really where the meat of sort of like the conceptualization is, and what we use to guide, what we are supposed to sort of like use to guide treatment. But as sort of like managed care and other sort of like changes took place in sort of like in psychiatry, and practice started sort of like visit times sort of like shorten, and we had like more and more structured note writing things, formulation kind of retreated, and sort of like diagnosis became the central thing, and this got reinforced with various sorts of practice guidelines which are all diagnosis based, and sort of like don't really focus on the personalization or conceptualization aspect. So I think that dynamic also reinforced that it's as if the diagnosis is giving you the understanding, and diagnosis is telling you the cause, and diagnosis is giving you an account of theology, when it's really not. It's the formulation that is supposed to be doing those things.
Yeah, again, when I'm working in like my adolescent PHP, all of my patients that I'm carrying have major depressive disorder, recurrent, severe, without psychosis, right? That's what, and they all have generalized anxiety disorder, right? That's what their diagnoses are. But they're all vastly different kids and teens, right? They have so
Yeah.
many different things that are going on that there's no way that that can be encapsulated in a diagnosis. And again, exactly what you're saying is the meat and potatoes, like where your the real worth of a psychiatrist as a whole comes from, is from that formulation, and then identifying what can we do to help each of those kind of stressors, those mitigating factors, versus just saying, well, major depression, generalized anxiety, here's some Zoloft, go on your way and feel better.
Yeah, and I think this sort of dynamic is what is, I think, driving sort of like the search for a lot of alternatives to the DSM, is that they're trying to sort of like break the hold of this categorical thinking. And especially, I think that has really hindered our sort of like scientific research, because for three decades, 3 to 4 decades, like a lot of our research has been oriented around single DSM categories. So we'll have like major depression versus normal control, schizophrenia versus normal control, and what we're sort of like finding is that these labels don't correspond to biology in any straightforward way. Like the neurobiology of the brain doesn't respect what the DSM diagnosis is going to be. These processes are transdiagnostic, and sort of like these categories are extremely heterogeneous. And if you look at the sort of like the psychological distribution of symptoms, it's all dimensional. Sort of like there's no sort of like clean break anywhere. So I think sort of like so I sort of like see it as a good thing that the cultural power of the DSM has weakened, and sort of like so now we have different sorts of other initiatives. Sort of like we have RDoc, sort of like for sort of like for research. We have HiTop for quantitative psychology. We have clinical characterization, sort of like to guide sort of like formulation kind of things. We have clinical staging models coming up. So I think that's really wonderful, because DSM was never intended to be sort of like this single manual to rule everything, right? It was just sort of like one effort, but somehow it became the only lens through which we understood psychiatry for 3 decades, and we're finally kind of like woken up, and we're like, we need other approaches too. We need other ways of conducting research and thinking about psychopathology.
Yeah, it's not Sauron's ring, right?
Yeah.
Um, in this kind of thread, in this way, a bit like, how can we, looking at this, improve psychiatry? How can we improve the field of psychiatry, or is it improving psychiatrists? Is the problem psychiatry, or is the problem psychiatrists?
Yeah, it's I guess sort of like it's a little bit of both, and I think sort of like the challenge that comes up, in my view, is that problems exist at multiple levels. I think we have certain sort of like problems at the conceptual level, sort of like then we have problems kind of like at the level of clinical practice, sort of like the ways in which clinical practice constrain, and then we have problems at the societal level, sort of like the general attitudes, and all of those sort of like things kind of feed into each other and mix until it becomes sort of like this like haphazard mess. And I think we have to address all of those things, sort of like one by one. And so I've been interested in a lot more on the conceptual side, so I've been kind of like talking about that. So so we, for example, we just spoke about DSM. So sort of like so this is often sort of like referred to as the reification of the DSM. That is sort of like we make abstract categories more concrete, and we attribute to them a reality that they don't possess, sort of like and then sort of like sort of like thinking more clearly about sort of like disorder concepts and pathologization. Sort of like is it a good idea that we call everything in a diagnostic manual a disorder? Like is it a good idea to call prolonged grief a disorder, or adjustment is a disorder, right? And what changes, what does it communicate to the patient, and sort of like how does it affect their self understanding? I think so this is something that we have kind of neglected. And so we have so that has resulted in dissatisfaction. Like people get a diagnosis of personality disorder, or they sort of like and in sort of like then they feel as if they some sort of that they have been wronged in some way, sort of like as if someone is saying that there's a part of you that is like broken, or sort of like so we haven't sort of like paid attention to sort of like the subtle meaning that these terms can weigh. And then I think there has been this sort of general reductionistic tendency, where I think we tend to reduce everything psychological to the brain level. Sort of like we want to sort of like we want to understand it in neurological terms. And I think this was the sentiment behind chemical imbalances and the decade of the brain, and all of this brain disorder talk. As if sort of like sort of like a psychological ailment couldn't have validity unless you show that there's a brain problem, right? So I think so those, I think, tendencies are, I think, real. I think those are problematic in the field. We need to counter them. I think then at the clinical level, I think the issue is that clinicians are working under sort of like a lot of constraints that are not good for clinical practice. They don't have enough time. They're burdened by documentation, and they are threatened by sort of like all of these sorts of lawsuits. So they're practicing very defensively. So the incentives that drive clinical practice are not for the benefit of the patient. They're for the benefit of the insurance companies and pharma companies and hospital administrators. So the incentives are all skewed, and patients are getting sort of like clinicians who are burnt out, who are sort of like who are stressed, who don't have enough time, and all they have time to do is sort of like give them a quick diagnosis, and here's your SSRI, or here's your stimulant, and then on to the next patient. So they're not getting sort of like the sort of comprehensive humanistic care that we need. And then at the societal level, sort of like there's this tremendous stigma around sort of like mental illness, and there's just sort of like this tremendous lack of resources and funding. Like we don't have sort of like enough money to provide services. Sort of like community clinics don't have resources. They don't have enough case managers, they don't have enough social workers, not enough therapists, right? So at the societal level, sort of like we have this issue of funding and resources and where the money is going. So unfortunately, sort of like we have to tackle all of them, but it's just sort of like it's difficult.
No, for sure. It's definitely like, I mean, I think you're talking about especially with in regards to just the mental health worker shortage, because it does cause us then to not do the work that we were trained to do, right? There's so many, I think psychiatry training across the board is fantastic. We pump out some good people, but we're not allowed to do the work that we were trained or that we're able to do. They apply, insurance companies and hospital administrators, again, they apply the kind of same idea that like, oh, we're like pediatricians in family care. We should be able to see people in 5 minutes or 15 minutes and keep going. And, I have the benefit of being able to spend time, at my private practice and then even at my other work with the hospital is like enough time with my patients. People are like, you're doing 60-minute, 90-minute evaluations, you're doing 30-minute follow-up visits. So I was like, yeah, that's all I know. And that's why I have the benefit to do that. And then, I have patients who come to me and they're like, oh, you want to ask me questions beyond how's my medicine? And it's kind of like, this is what's been kind of drilled into people's head, is that we're just the pill pushers and we're the prescription pad, when we have the training and the ability to do so much more. We're just, so many of us are not allowed to do that, and we're just not able to do that.
Yeah. Even when sort of like when I think clinicians want to do better, they don't get sort of like help and resources and the right sort of environment from the system and from the hospitals to do that. And I think patients, they don't get to see what's happening behind the scenes. Sort of like they sort of like their direct contact is basically with the clinician. So it's sort of so all of the frustrations and grievances that they have against the medical healthcare system in general, they kind of get focused on the clinician, and sort of like clinicians often end up being blamed for a lot of like problems and issues that are out of their control.
Yeah. And I think this is like really brought up. I mean, you had done something with New York Times that kind of choose your own adventure
Yeah.
almost in a way of like, what happens if you're feeling a little bit sad and you want to get some help. So talked about a little bit about how that kind of came about. It was really, really kind of cool and interesting, and highlighted some of these issues and problems.
Yeah, it was sort of like it was. I was working with the New York Times sort of like opinion team, and we were kind of wondering like sort of like how do we convey to the general public what it's like sort of like receiving care, and sort of like not simply from the patient perspective but from like the clinician perspective, and sort of like and what's the thought process that go into it, and what are the system constraints that go into it, and also sort of like why is it that so many people they seek help, sort of like like the message everyone is getting is like if you're suffering, go talk to a doctor. If you're depressed, go talk to your doctor. But when they go talk to their doctor, they don't get better, or they don't get the help they need, or it's just like an endless cycle of medication after medication. So like why is that happening? So that was sort of like the that whole choose your own adventure type thing was designed to kind of like walk people through that whole experience and expose them, one, to sort of like it's just sort of like the fact that the medications we have are effective, but they're not magic bullets. Sort of like they work only to a certain extent, and there's an unavoidable element of trial and error involved at the moment, because we don't have, the science is not there yet where we can personalize. We can't predict which medication would work for which someone. So that inevitably sort of like there's that element, and then there's there's about sort of like like a 33% or so some subset of patients that just don't respond to standard medications at all, right? And so like so getting through all of those trials and getting to a point where realizing that none of that is working for you, and where you're trying to get psychotherapy, but you're not getting the right software that you need, and you're getting suboptimal care. So it was just sort of like it was intended as sort of like this sort of like wake up call for people that like this is what's going on, and it's kind of like just kind of like to force them to think a little bit about sort of like these forces operating on clinical practice.
Yeah, I think I did it, and I think I had a very good outcome. I think I did like a watch and wait, and then my depression got better after watching and waiting miraculously. I was like, yes, I
Yeah.
win. But I was like, I know how uncommon that is, and we hear this, especially in you're in Cleveland, I'm in outside of DC area, like there's academic resources, centers where you're at and where I'm at, so there's access at times, but like when we go to like other Midwest kind of cities or states where there's nobody, like, and like people are waiting 6 months, a year to see somebody, And it's like, what are you supposed to do? Just when there's emergencies, tell somebody, like, go wait for 6 months and hopefully we'll see you then. Like, it doesn't work. So
Yeah, yeah, it's really it's sort of like there's tremendous need, and which is sort of like why I'm kind of like generally skeptical of sort of like some of the more sort of like rhetorical kind of ideas that we can just like abolish psychiatry, we can just eliminate, I mean, like because when you sort of like see how much need there is and how much people are suffering and how long they're waiting, sort of like we need sort of there is a need for a medical profession that
yeah.
sort of like that tackles these problems, and I don't think that's going to go away anytime soon.
No, I've said it as like, I've said it multiple times as like, I could clone myself 10 times and work 24 hours around the clock, and in my lifetime it won't make a dent in, and what in my local area. So it's just a ridiculous amount of need. So
Yeah, the challenge though is sort of like that I think because there's such shortage, people are like, well, sort of like substandard care is better than no care. So they sort of like they they use, for example, sort of like sometimes mid levels with inadequate training, or sort of like they just like overburden clinicians, and then patients sort of like end up being dissatisfied or harmed by the treatment they're receiving. And I think we really have to be careful that in an effort to sort of like make treatment more accessible, we do have to maintain certain standards, because a lot of times substandard care can actually be worse than no care.
yeah, I fully agree with that. Is I've said it before, is that like, bad psychiatric care is worse, much worse than no psychiatric care. And I think it's something that we have to kind of keep that in mind. So you've talked about, or you've advocated for, conceptual competence in psychiatric education. What is that? What do you mean by that?
Yeah, so it's so this is sort of like a proposal that this was a paper in 2020 and then sort of like in print in 2021 in Academic Psychiatry, where Scott Waterman, he's also another psychiatrist in the philosophy of psychiatry community, we kind of like we made a case for including conceptual competence in psychiatric training, and we sort of like we said that we talk about cultural competence, sort of like right, sort of like being aware of how different cultural differences influence psychiatric presentations and care, and we talk of structural competence, how all of these societal sort of like power structures and inequalities affect psychiatric care. And so just as we expect clinicians to be competent in these areas, we also sort of like need that clinicians to be competent in thinking clearly about the concepts that they're using, and sort of like the sort of like the assumptions that they're working with, and in a way sort of like this is a way of incorporating um, like insights from like philosophy of psychiatry into psychiatric education, but in a manner that is clinically relevant, sort of like in a manner that is relevant for psychiatric research and psychiatric education. Because because a lot of time when they think about philosophy of psychiatry, they think of sort of like some of the more obscure philosophers. They might think of like Wittgenstein, or sort of like Sartre, or and they're like sort of like what does that have to do with clinical practice? But really, I think sort of like the essence is that it's about thinking clearly about the concepts that we are using, and sort of like thinking clearly about the assumptions that guide them, because these assumptions sort of like make a difference. Like if you like I said, if you diagnose a patient using the DSM, and you have this sort of like this reified view of the DSM, where each category is a distinct sort of like disorder with its own dysfunction, your care sort of like is very different than someone who uses DSM as pragmatic categories, as sort of like or someone sort of like someone who's operating with a reductionistic sort of mindset versus someone who's sort of like operating with a pluralistic mindset, etc. So it's basically a way to sort of like advocate for like how do we get psychiatric trainees to think more sort of like more clearly and sort of like more openly about these concepts and terms sort of like that we're using. That how do we get them to think about if I call someone, if I say that something is a disorder, what do I mean by that? If a patient asks me that you have diagnosed me, like what does that mean, right? And so that they're able to coherently explain it to them. So it's this sort of like it's emphasizing the conceptual side of psychiatry, that this is something we have neglected, but this is an essential part of what we do as psychiatrists.
Yeah, I think that's really important because we definitely have more of the U generation, the Gen Z, where people are wanting to be and should be informed of what's going on and how their own health, their own mental health, everything like that, and being able to take advocacy and have a good understanding of and being autonomous. So
Yeah, and I think that it's good that we have sort of like I think some really excellent role models. So, for example, I think we have a mutual admiration for Kenneth Kendler, who's sort of wonderful psychiatrist and researcher,
yeah,
but also like very well known name in philosophy of psychiatry. And I think he has done a lot to sort of like bring some of these conceptual issues to sort of like to the consciousness of the psychiatric sort of like scientific community. I think we have some great role models there to sort of like this is not sort of like just discussions that are happening, let's
yeah,
say sort of like by by the humanities or sort of like other things like that. These are discussions that are taking place within the scientific community in very robust ways.
yeah. We Where do you see the field kind of going? I know there are people who are very much in the biological camp and saying like, we have these companies, GeneSight and Genomind, that are popping up, and there's the research and everything that's in there. Where do you see kind of like the field of psychiatry going as a whole? Then,
Yeah. So I guess sort of like there are sort of like directions in which I would like the field to go, and then sort of like there are directions that it may actually take in practice, and they're not really going to match. But I think sort of like what I would sort of like really like, I think, is sort of like is for psychiatry to become sort of like much more pluralistic and much more sort of like multidimensional in sort of like in its thinking and scope. And I think we're already seeing signs of that sort of like signs of that happening. And I want that to happen sort of like both scientifically as well as sort of like clinically and ethically and sort of like politically. So, for example, on the scientific side, as I mentioned, sort of like well, we are giving up this reliance on sort of like on the DSM as sort of like as the only sort of like tool we are using, and we are kind of exploring these other ways of understanding psychopathology and psychiatric distress. So I think it's completely right that we need like some approaches that are focused on brain functioning and trying to understand sort of like how brain functioning connects to various sorts of psychological phenomena. We need sort of like a quantitative approaches that are looking at how symptoms kind of co-vary and how symptoms kind of match, and then sort of like we need other forms of sort of like research strategies that are looking at, for example, development and clinical staging, right? And we also sort of like need methods that are sort of like coming in from other disciplines. So sort of like we're looking at from sort of like thinking from complex dynamic systems, and sort of like we're sort of like taking inspirations from our colleagues in neuroscience. So I think all of that sort of like I think we're kind of heading in the right direction. The second sort of like I think that needs to happen is that I think psychiatry needs to become more democratic. And I think this is because compared to other medical specialties, there's a more prominent element of social control in sort of like in a field. And so, for better or worse, psychiatry has been tasked to deal with a variety of harmful states, where there is a serious or imminent risk of someone harming themselves, or sort of like where there's risk for like violence, or there's risk for public disruption, or risk of sort of like grave disability and self-neglect. So the burden has fallen onto psychiatry's shoulder to kind of like to make sure that the patient stays safe in conditions like that. And but the end result sort of like is that when anytime you exercise power, and anytime sort of like exercise control, there are downsides, and sort of like and some people are traumatized, and some people have really terrible experiences, and especially if all of that is happening in a very underfunded system. And I think sort of like in right now, I think the public perception is that, oh, sort of like, it's like psychiatry is claiming this illegitimate authority of sort of like, of coercing us, and sort of like, and we just sort of like, we need to like remove psychiatrists from this equation and everything will be all right. And they're missing the fact how sort of like the sort of like the mandate is coming from the society and from the law and all of those things. And I think this is where I think psychiatry needs to be open about what is happening. Sort of like, it needs to be sort of like, like this is why these things are happening. These are the considerations, like, you're not being involuntary detained because of this DSM diagnosis. You're being involuntary detained because of these sort of like risk factors or risk criteria, and these are risk criteria that are enshrined in the law or whatever. And that way, like the society can have a democratic discussion. Sort of like, they can decide sort of like, what sort of laws they want, or sort of like what sort of better sort of like things to campaign for. And I think that takes a little bit of the pressure out off psychiatry too. And I think sort of like it makes things more sort of like, it makes things more transparent, and it gives people power in having and sort of like say in sort of like, what they want the laws and sort of like and the politics to be.
Yeah. Why is it important for psychiatrists to be engaging in these discussions? Why is it important for them to be on things like social media, having discussions with people who may have differing opinions, versus just sitting in a box and just writing prescriptions all day?
Yeah, and I mean, so I think this is this is sort of what has been happening, in the last couple of decades, is that clinicians have just been kind of like interested in the clinical work and the scientific work, but that doesn't sort of like stop the conversations from happening. And as sort of like as you're aware, and sort of others who are active in the public sphere kind of know that these discussions are taking place with or without us. And when they happen without us, sort of like all sorts of misunderstandings and misinformation and sort of like distorted ideas kind of influence them. And I think sort of like the reason is that one sort of like I think psychiatry is just sort of like it's comparatively early in its scientific development. Sort of like we just we don't know a lot of things about sort of like about how brains work, about how mind works. Like even sort of like a lot of sort of like basic scientific things are kind of uncertain. And then sort of like unfortunately, sort of like the interventions that we have at our disposal, they have some degree of sort of like efficacy constraints, and they have adverse effects, and sort of like and then sort of like we have this coercive side. So like the bottom line is that people are going to be dissatisfied. It's inevitable. A certain subset of patients who receive psychiatric care are going to be unhappy with that. They're going to have negative experiences. They're going to sort of like be traumatized, and they're going to speak up naturally. Sort of like and it's sort of like it's the right to speak up, but sort of like there's going to be that element of sort of like discontent. And sort of like and the more we ignore that, the more sort of like the more vocal sort of like those voices kind of would become in the public sphere. And it would sort of like it's kind of like start setting up a dynamic that's kind of unhealthy for everyone. And so I think sort of like ignoring that doesn't help anyone. Sort of like it doesn't help sort of like those people. It doesn't help the profession. It just in fact it's sort of like it just like sets up this sort of like dynamic where people sort of like become more and more traumatized, more and more angry, and they're just like we're just if psychiatry is not going to engage with us, we can just we're gonna have these conversations without them, and we're gonna try to sort of like talk to the politicians without them, and sort of like so I think for the sake of our own profession, sort of like I think we need to be active, and I think we need to sort of like for one sort of like genuinely listen and sort of like figure out sort of like what is driving all of this sort of like there's sort of like what are the reasons patients are dissatisfied, because we have a responsibility to them. We have a responsibility not just to the people who get better with our treatment, but also sort of like people who end up being harmed in a wide variety of ways. So we have to listen to them, and we have a responsibility to try to do whatever we can collectively to sort of like to remedy that. So I think and we can only do that if we are an active participant. Otherwise, we're not going to be exposed to that.
Yeah, I think that's the big kind of takeaway is that for we tell our patients all the time the same thing is like, we ask for feedback from, or we ask them to receive feedback and to get better and improve. We have to do the same thing as a field, right? We have to be able to look at ourselves. We have to hear what the critiques are, see what we are doing wrong. Are we doing something wrong? Probably, maybe. And then try to make some changes so that we can keep improving this field. It's something, we brought it up a little. I was asking before, like, is it psychiatry or is it a psychiatrist problem? I was like, we're both Pakistani Muslims. I can say is like, I, with Islam, the religion itself it's a beautiful religion, right? We're biased maybe. But I think there's a lot of Muslims who give it such a poor image. And it's a similar kind of thing. It's, psychiatry can be a very beautiful thing, but there's a lot of psychiatrists who give it a very, very terrible image. And unless we fix that and change that, it's just going to keep perpetuating.
Yeah, I mean, I think there's something about sort of like this analogy with religion. I personally have a complicated relationship with religion, but I sort of like, I certainly sort of like see that. I think where you have some people like the new atheists who sort of like, who see religion in a very literal sort of way, where it's just sort of like, it's just, some fairy tale that people kind of foolishly believe in, and it's causing all of these problems in society, and the best thing we can do is just sort of like, eliminate that. Versus sort of like, there's this other sort of like rich understanding of religion as sort of like, where it sort of like, it serves as a source of morality and sort of like, a guidance, sort of like, and where you can use it to sort of like, improve your life and improve the life of others, right? And so there are different ways in which we can sort of like, understand and approach sort of like, religion. And if we let sort of like, the more sort of like, extremist or fundamentalist sort of like type of people become the image of the religion or the spokesperson, then sort of like, you're gonna correspondingly sort of like have that sort of backlash. And I think, unfortunately, I think a lot of the people, have that sort of image of psychiatry where sort of like this, like, oh, like psychiatrists are pill pushers, only interested in the disease model, and sort of like, they're just like, they just think about the brain, and they don't care about lived experience, they don't care about phenomenology, they don't care about all of these other things. They don't sort of like care about the humanistic dimension of clinical care, and it's up to us to change that.
Yeah, no, 100%. So wrapping up a bit, I always ask all my people on here, how do you take care of yourself, right? Because we always preach to our patients, self-care, take care of ourselves. What is your self-care?
I think sort of like I think it's I think in psychiatry and psychology, we place a lot of emphasis on like boundaries, and I think it really comes down to sort of like, setting boundaries in kind of some way, sort of like, and sort of like, and even sort of like, when we are active online, there's sort of like, there's only so much engagement sort of like, we can sort of like, be a part of. Especially sort of like, if you have, even sort of like a remotely decent social media presence, you're gonna be sort of like, engaging with like thousands of people, and you're gonna be getting sort of like, so many sort of like different people tagging you or sort of like replying to you and commenting you. And we have to be sort of like, we have to be careful in sort of like, what sort of content we engage with, and sort of like, what sort of like, perspectives we kind of like, give more priority to. Because I think sort of like, if we kind of I think if we can get caught up, and I think it's sort of like, it can sort of like really negatively affect sort of like, our mental well-being. And so I think it's sort of like really important to have some idea of like, where my boundaries are going to be, sort of like, how I'm going to limit my engagement and keep it in a way that is sort of like, it's positive and productive.
Yeah, I know, like, after a long time, I was able to take like a vacation out of country over the summertime for like that 1 week where I like was able to disconnect. It was great.
Yeah.
It was fantastic.
Yeah, and I think sort of like, I think burnout right now is a problem across like
Hmm.
medicine and sort of like, and psychology. And I think the systems that we work in, they want to sort of like, they want to get sort of like, as much work out of us as they can.
Yeah.
And so making sure that sort of like, we're getting sort of like, that we are, you know devoting enough attention to ourselves, to our families, or if like we're taking time off, it becomes even more important.
1000%, 1000%. Well, Dr. Aftab, any last kind of statements or things you want to pass along to anybody who may be listening or watching?
I think I'll just sort of like I'll just like reiterate the importance of I think thinking about sort of like psychiatry with more sort of like conceptual clarity and philosophical clarity, and sort of like and thinking about sort of like like how sort of like these things influence self understanding of patients. And like so I would encourage like all clinicians, like not just be sort of like content with giving a patient a diagnosis, kind of like explore with them sort of like what does this mean to you, how do you understand this, sort of like what do you think I'm telling you, and sort of like and you would be surprised sort of like what they tell you. And sort of like I think if you make an effort to sort of like spend some time with them and make sure that what you are communicating is sort of like is conceptually and scientifically accurate and correct, that would go a long way in solving the problems that we have when it comes to clinical interactions in psychiatry.
Yeah, I think it's a great, great message. I think it's one of the greatest takeaways that I've had from like being on social media a bit more and interacting like with, TikTok and Instagram and all this Twitter stuff is hearing from people who are not my patients but are patients of somebody else, and hearing back from them, and I've been able to really learn so much from being able to do that. And I really encourage everybody to kind of learn from that aspect of it.
Yeah, yeah,
So
I agree. So hopefully people who are listening sort of like it makes an impression.
yeah, well, thank you. I know I've learned so much just from even spending this hour with you. I'm sure everybody else has been able to learn a bit too. So thank you again.
Thank you. Thanks for having me.
All right.